So this is me, privileged to chair the Immunisation Coalition, and a great opportunity to talk to everyone today about what's happening, where we are with our... So I want to talk a bit about what it felt like in general practice, some of the things that we're facing and the real emotional pressure that we felt. And so I looked at some of the international literature. So one of the first things that general practice was feeling is that they needed to get information they can rely on. And we've seen that they did have an important part to play, and they knew that, and it was important. Find something that they could rely on, and then for a whole lot of reasons, the bottom line was this real sense of not so much mistrust, but just the messages coming out, not only in Australia, but it was changing, and it meant that what general practice was trying to present to its patient load as people came in to talk to them had to battle what the government and social media and other people were telling it. The Canadians saw this and struggled a lot with it, and they've written a lot about it, and there was a bit of that in Australia. We found that general practice was adaptable because we had to, and I think all of us were changing. But very quickly it became obvious that you could talk to people on the phone, you could try all these fancy new IT, but there were limits. And I'll talk about that a bit later. And also the fact that not only in Australia but around the world, that it seemed that nursing homes and hospitals ended up with all the personal protective equipment, and it didn't land in the community where those of us who were out there on the front line were asking for that support. So as we were trying to do the right thing, still trying to conduct business as usual, still trying to do all the things that were absolutely necessary, there wasn't that support. So again, the trust in the people who said, yes, we'll get you equipment, wasn't very good. And what we felt was that GPs were trying to listen to what the government said, make sure they've got the right policy. They were interpreting that, they were getting information through whatever source they decided they needed. And then they were trying to translate that. So a whole lot of noise, and then patients were coming and saying, yeah, but what does this mean in that trusted relationship? And in the consulting room, it was where that anger met on a face-to-face personal basis, because the patients were frustrated by different informations. We've just heard about the people who didn't want to be vaccinated or had some resistance or were concerned about it or got anxious. So they were talking about this. So you had this tension where during the consultation there was a tension between what the patient had informed themselves. They were being threatened by COVID directly. They were looking for information as well. They were often looking to government, or they had their other sources. As Katie was showing us, they were becoming maybe resistant. And then when they actually talked to someone that they'd maybe known for 20 or 30 years and they said, well, what do we do about it? What's your thoughts? And the doctors were trying to say, this is what we believe, this is what we understand. Sure, it's complicated. And in this Canadian paper, they were saying that it led to this overtly adversarial and often toxic environment. And it was literally in the face of anyone trying to discuss, anyone giving a vaccine, anyone talking, was actually getting that on a personal basis as the patients were struggling with their information, sometimes well-informed, sometimes well-intentioned, but then the anxiety that evokes means that the person they're going to talk to about that particular issue and the rest of their health is under pressure. And what I thought was really interesting when you look at creating a distorted picture of how experts and decision makers communicate, especially in a time of crisis. Now, those of us who know about the scientific process and what you need to do to actually say, well, we've got a fair idea that it works. You know, we first know the vaccines are about 80%, 90% effective. What does that mean? You've got some data about what the disease is. We don't understand how it's transmitted exactly. We don't know whether it's droplets or aerosol and are the masks going to work and all that sort of stuff. So scientific discussion has a way, if you're in that world, of actually saying, well, this is what we know, this is what we don't know. It's a probability, probably certain. It's more certain, we're pretty certain. And it's like, how do you translate that to on a day-to-day basis of what does that actually mean? Are you sure? And again, as Katie says, it's like, well, someone's vaccinated, they've still got infection and they still pass it on to someone else. So what's this about? So it just creates that extra tension. So the new jargon that's in our notes is F2F. So we're all talking about face-to-face. So that's when you actually see somebody. We phone people, we email, we Zoom. So I've sent a whole lot of comments and questions out to the colleagues that I work with. Thanks to John Litt. So he and I did a lot of work on this, and as a good academic, he sent me lots of papers on it. And looking at what the patients are telling me on a day-to-day basis and the social media, and it's ongoing. And as I was writing these slides on a Sunday morning, I got a call from the nursing home and went down to certify the death of this lady. So this was in her records. So she'd survived dementia, she'd survived breast cancer. She's obviously unwell. She'd been in the nursing home for a while, and then so I saw this was she died on the 4th of June, and she was COVID positive 3 or 4 weeks before. And so the question was, well, do I say COVID killed her, or was it really her dementia or her breast cancer or whatever? But it's still there, so it's quietly moving people on. It's in our nursing home. It's literally on a day-to-day basis. We're certifying people who probably died earlier than they would have if COVID hadn't been around. So looking at some of the wording that people were using as we try to understand exactly what's happening here. So it's a complex impact. We need to make sure we can balance against what we can do, what we can't do. It's a reduction in actual services, so people are missing out on support. Internationally, it's agreed that general practice still is a cornerstone part, so primary care is important. It is highly adaptable. There are unique demands that we need to be conscious of, but it needs equipment, it needs training, and it needs support financially. In Europe, they talked about the advantage of general practice is that you can actually look at risk groups, so you can know who's particularly vulnerable, so you should be able to target and focus. You should be able to monitor whether people have had it because you're seeing them and talking to them. You should be able to individualise care, and also you can you're picking up and monitoring it and reporting. And it's suggested that maybe there's a message there that says try to get general practice more involved in public health programs. I think the British are talking about good, fast and cheap, but if you try all three of them, it doesn't work because it can't be all three of those. And lamenting, questioning and wondering what the future is with the continuity of care. What about the relationship? Where does that fit? What they talk about as the relational model. That's good for long-term care. Where does it fit? Is the trust useful? Can it transmit a message? And people say, well, you say, so I'll do it. The doctor who's been there for their whole life, seen their children, seen their grandparents, can interpret their lived experience and try to translate and reassure them that it's safe to have a vaccine. All of that sort of stuff is now under question. But we know that continuity of care is associated with patient satisfaction. It helps better advice transfer, it helps compliance. People adhere to the advice if there is trust in a long-term relationship. Studies have shown there's less emergency visits if there is that, and less admissions to hospital. So we know it works, but where does it fit in this new tested environment? So we all now agree that we need to have face-to-face, still fitting if we have remote consultations, but there is a concern that we're going to miss things, and certainly I've got patients where we've missed early onset of diabetes and breast cancer just recently that probably missed because of COVID. But any communication, direct, quickly, faster, is better if the patient already knows the doctor and vice versa. And really the challenge is to work out now what are we actually going to keep and what are we going to do. So in trying to summarise what I think should have happened, and some of it hasn't. So where does telehealth fit? Are patients getting the hang of looking after themselves? How do we look after the at-risk and maintain that link between acute and chronic? So this is going to be an ongoing thing. The studies are showing that almost everyone uses the telephone. They don't use anything else too complicated. That 2/3 of consults are virtual, so that seems to be about where the market has stopped, that anything less than 1/3 is probably and at least half, or about half the doctors are saying they will continue to use telehealth. So that's interesting. Some people say they won't, but patients don't always have the technology at the other end, can't rely on it, still not integrated with our IT system, so that's a barrier. And they say in the country areas, the IT never works, and in urban it gets overutilised. Self-management support, I think there's a big gap, didn't happen. When you think about it, wouldn't it be good if we would use this as an opportunity to say, right, you can manage yourself, all that self-directed learning, and didn't really happen. And proactive care, that was, I think, a mixed response. So one study said that people didn't come to care because they were scared they're going to transmit the disease, or they didn't want to come in. They would think they were doing the right thing by trying to be isolated because they got the message that don't go and see anyone. And then, oh, but if you get sick, you better come and see anyone. It's like, well, how does that work? There's a good paper looking at, I'm hesitant to visit, so people were staying away. But on the other hand, if you go and see someone that you used to seeing, and primary care is an ideal position to actually pick up those groups. This whole thing about maintaining that relationship between acute and the community sector, I think, is under challenge. Got a half dozen points here that the concern in the general practice literature is that young families and people grow up thinking it doesn't matter who, just as long as you get any contact with the health system, that's good enough. So solve the problem in the short term, signpost them, send them off somewhere else. That's what the system needs to do. As long as someone sees them, whether it's the GP or the specialist or the podiatrist. And this whole continuity of care is under threat. And then it becomes increasingly difficult to see a GP for all the reasons we know. And it's not a career that new doctors are looking at because this partnership relationship model, and it's been questioned about where it actually fits. So there's a whole lot of soul searching to see where it's going to be in the future. And most of us think the funding model reform, maybe politicians are considering it, but they haven't actually done it. So I think the $15 or $20 increase that might happen to a third of our patients in November isn't really going to solve the problem and the funding. So internationally, I think it is agreed that there is a place for primary health care. We supposedly can learn. So the Middle Eastern virus and the previous SARS outbreak in Taiwan and China and Singapore, we think help them manage it better. We need to integrate it with the public health system. We need to work on our clear messaging and support each other to get the message to be working. And a fully functional primary care workforce actually needs further support, otherwise it's at risk of falling, and there's a real soul searching as to whether it's actually going to work in the future. So it's had a complex effect on primary care. Sometimes it's created the opportunity through the phone and the virtual consultations to actually get a better communication and make it easier, because sometimes doing repeat consultations is easier and you can do it on the phone. But it changes our resourcing. Information flow is affected, and the comprehensiveness of the service is still to be evaluated, and actually where that's going to fit and how we actually balance it is still up for grabs. It's still important to have primary health care, whether it's just GPs, but it's people on the front line need to be supported because it has to go. It is highly adaptable. It can adjust, and it provides patients with an opportunity to get their unique situation, their unique demands actually addressed, because if they don't have that, then they're looking at a population health message, and then they've got to translate it for their own personal life. And it's important, and that's where that frontline response is really important. But it needs to be resourced. It needs the proper equipment. So things just like IT, both the doctors and the patients need to be able to talk. They need good electronic medical health records that integrate all of this material. It's getting better, but it's still disjointed. They need support and training to make sure. Currently, we need to do a 2-hour training on how to give a vaccine. Apart from that, a lot of the other things are new and different in how we actually manage this. And the financing is agreed around the world is probably a major issue that isn't happening. So as still certifying and seeing patients die in the nursing home, it is still out there. It's got a long tail, and I haven't even touched on the impact of long COVID, where that fits the diagnosis, who's going to management, who's going to be the best group to support it. Most people think general practice should be in a position to look after patients with long COVID, but it's not being resourced, and I think nationally the Commonwealth is waiting for the states to fund it, and the states are waiting for the Commonwealth to fund it. So the states don't have the infrastructure or the support, and so the hospitals and the secondary care sector is underfunded, finding it difficult. Patients who have long COVID don't know where to go, and the GPs don't have any mechanism to provide insight or support and can't integrate. So it's got a long tail, it's still out there, and it's still a challenge. So thank you very much. So I'm happy to answer questions about that, or we can talk about football, or we can talk about the cricket. Got a question here. Chronic conditions take up most of primary care time. Acute and proactive viral and bacterial infection and immunisations are now more front and centre. COVID has raised this, but we have 7-minute consultations. What's the answer to giving better patient-focused care? Nurses and pharmacy to take more responsibility, or more important, general practice, or a mixture of all? So I'll answer that, but Paul?
Thanks, Rod. I mean, I think this, and I actually saw this from both respiratory clinics and general practice. It's the first time I've ever been involved in a protracted problem where the information I received was via press conferences rather than communication from the government or anything else. What particularly worries me at the moment is the failure that we continue to see in aged care. You know, where on a given day we have 500 outbreaks in Australia in aged care. 3,000 people are ill, 1,000 of the staff are ill, and our booster dose coverage is just under 50%, and that's double what it was a month ago. Health Ed did a survey for me asking why we couldn't get them vaccinated. A fair proportion of general practice had stopped giving any COVID vaccine, appeared to be quite happy to have the pharmacy down the road provide the bivalents. They complained that the funding model wasn't adequate, so that they're happy to go and give a flu vaccine but not give a COVID vaccine at the same time. How do we actually do something to try and start protecting these people who are dying at the rate of 20 a day in aged care by using the fact that they all have a general practitioner lift to their particular care, but we're not managing to do it? Will the new Moderna vaccine, which is a single syringe instead of trying to mix up bits out of a vial, will that make any difference, or have you just given up on the capacity of general practice to protect aged care staff and patients?
Yeah, thank you. The literature around the world says that it agrees with exactly that, Paul, is that for general practice to continue to be part of this, it needs to be supported. And the question is how to support it. And going to the first question about, is it just the general practice, or is it setting up new systems? And so the trade-off we get and the concern we get is this, if the system is just signposting, say you need to go here for this, you need to go here for that, you need to go to wherever it suits me at the time. It might be a state government program, a federal government program, or the pharmacist or the GP. That signposting doesn't provide a long-term relationship issue. And all of the problems we've had by not having continuity of care, that trust that's been built up for years, and the ability to make an understanding of what that person's needs are and how to do it is under threat because we haven't worked that out. So that's a question that everyone's asking. Most people say it needs more support at the front end. Just remember back to the 90s when immunisation rates in Australia were 55%. The federal government agreed to invest in primary health care. They funded, in inverted commas, the general practitioner, but the funding was to support the general practitioner to be able to employ nurses. The funding meant that the GPs could afford the equipment. So the $18 that was given for vaccinating somebody on time was so that they could actually put a fridge that was actually properly calibrated. They could actually afford to have a nurse looking at the numbers, they could have a nurse giving the vaccines. So this idea that you've got to pay general practice as the body that will employ the people to do that. The risk we've got is the money goes straight to the nurses, separate from going to the GPs, which is separate to the pharmacists, and there's nothing that's actually linking. And I think the risk in aged care, and we certainly noticed that too, at 40%, 43% immunisation rates in the nursing home, we just went up and said to the nursing home, we're coming next week and we're going to vaccinate everyone. And I did a tour around the country, drove around country South Australia for a day, vaccinated over 100 patients just to bring up the numbers in their nursing homes because people weren't doing it. And it just seems that the federal government and maybe the acute sector is saying, well, it's not our problem anymore, it's yours, and it's going to kill people. So it's a real problem, a real challenge with unclear answers, and really that's on our plate to fix. Yeah, question.
Thanks, Rod. Chris Blythe. You mentioned the funding issue, and I think everyone in the room recognised the importance of funding reform. I'm keen to press you on what is the optimal relationship between general practice, state health and Commonwealth health? Clearly working cohesively is about relationships, and I'm really keen to understand what that looks like for the next pandemic so that we can do better.
Well, I'd like to think that out of this work is that there's actually recognition from the state and Commonwealth that actually primary care needs to be supported and is recognised as a part of it. When I was chair of the AMA Council of General Practice, I think it was about 2006 when we were looking at some pandemic work, GPs weren't considered important or frontline people who needed vaccines in a pandemic, and so we had to actually convince the Commonwealth that it was important to put general practitioners, because we're talking about where the police need to be looked after. So general practice needs to be part of it. Our federal system, Kevin Rudd articulated that the federal system pays a lot for general practice and primary care. The states look after the hospital sector. So if you work at a state level, good relationship between the state and the hospitals, the acute care sector, because of the way the funding system works. And then the Commonwealth funds a lot of primary care, and so there's a disconnect because the Commonwealth is looking after that the way they fund it. And as an advocate for general practice, the best way to push forward GP's agenda is actually go and talk to the federal government, because they fund most of general practice. Yet the problems occur at the state level and our interactions with the hospital. So we've got a huge disconnect. So I think the first thing is to recognise that primary care has a place. It's important for primary care to say this is the place, this is what we can offer, and it's a genuine place in the system, not to say it's the only place. And we did that successfully by integrating general practice into immunisation. So it's done by GPs and it's done by pharmacists, done by local government, and the states and the Commonwealth support it. So we've got a model that integrates them, and at the moment I don't think that's recognised, and we've still got some major barriers because of the funding system between the Commonwealth and the state. So recognise general practice, work out a system that helps us integrate it, and we've had it said before, should it be run by the Commonwealth, should it be the state? It doesn't matter as long as you're talking and integrating it. Thank you. All right, so I think that's it. So thank you.